Hi, guys. It's Dr. Danny Shabban with Dominion Women's Health, and welcome to our podcast number 22-443, which I have no idea what that means, but we're going to just move on. Today, I know I've talked about it before, but I saw a patient last week that it was just so frustrating in her healthcare management that I wanted to do another podcast on PCOS, which stands for polycystic ovarian syndrome. So PCOS has been around for a long time. I remember when I was in med school, they used to call it Stein-Leventhal syndrome, and the infertility doctors would see these cysts on ovaries. And then back in the late 90s, early 2000s, they found PCOS. And the frustrating thing with PCOS is it affects over 6 million women in the United States. And nearly 70% of these women go undiagnosed. And you ask, why do they go undiagnosed if there's 7 million, up to over 6 million, close to 7 million women? Well, a lot of patients are being seen by primary care, family practice doctors, even OBGYNs. And it's being ignored until we get to the point in life where you're treating the symptoms of PCOS instead of PCOS, the disease. And I'm happy to announce Britney, Roadie, is with me today, who is one of the nurses, administrators in our practice. But talking about like PCOS is you'll have certain types of symptoms with PCOS that are suggestive of it. It's not diagnostic. So we do a workup, but if I have a patient who's having irregular menstrual cycles, hirsutism, which means hair growth in places you don't want hair. If you have hair on the face, the chin, the chest, around the lower part of the abdomen, that's considered hirsutism, especially with the face. Unwanted acne and weight gain. That most of my PCOS patients talk about, like when they were 14, 15, they started gaining weight. Their diet hasn't changed, but they noticed that each year they're gaining 15 to 30 pounds, which is crazy. And their metabolism has slowed down. So we look at that. There's a thing called hidradenitis, which is the increase in androgens in your body. You get the boils between your legs, under your armpits, or right under your breast. And I'll get patients that have been treated for it for years and no one's ever addressed the PCOS. The other big thing that finally is being addressed is with PCOS is mood changes. Anxiety and depression are a huge part of it. As a woman is getting older, she's in her 20s and 30s, she's noticing all these things. It starts affecting your anxiety and depression, and it affects your relationship. So, I mean, Brittany, you've seen it. You've been with us for over 12 years. You've seen it where a patient comes into the office for an UGYN, and as soon as I mention it, what's the first thing they say?
Yeah, it's scary how aware you are when you go into a room just looking at the patient. And I guess because I've been working with you for so long now, walking into the room with you, it's also resonated in my mind like, oh my gosh, she has PCOS and she's a 30-year-old who's been trying to get pregnant for 5 years and she can. And then Dr. Shabban will list off just, have you experienced this? Have you experienced this? And the patient is, yep. And then talking about depression and anxiety, Dr. Shabban will talk about progesterone kind of increasing the depression and anxiety. So he'll ask them about the Liletta IUD or the Mirena IUD or the Depo shot. Did you notice an increase in depression and anxiety or weight gain, your mood changes fluctuating with these birth controls? And then as soon as you had it removed or you stopped it, your symptoms got better. And patients are like, they're mind blown. You can see the look on their face like, oh my gosh, is this man a mind reader? Which he's not. But it's, yes, it is. It's sad that it's so underdiagnosed and women have to suffer with PCOS for so long and not get any answers. And then it's kind of, but it's also good to see by the time they see Dr. Shabban, you know, it's a sense of relief that just washes over them.
Well, and it makes me feel good knowing that there's other providers out there that are addressing it. I mean, if you think about it, and this is the part that it really pisses me off, is if you look at African American women, Hispanic women, Arab women, I feel like when it comes to PCOS and this form of healthcare, it's ignored.
It's very much just you're overweight or you're pre-diabetic is like the first thing that their providers say to them is the issue, without really diving into what are your symptoms, let's do some blood work, let's do an ultrasound. I think it's just immediately, well, and not family history is obviously very important, but the first thing that their providers go to is, well, lose some weight, you're probably pre-diabetic, you know, start diet and exercise and we'll see you in 6 months. And these patients are dieting and they are exercising, but because of the PCOS and their androgen levels and their hormones, nothing's giving. So then it just kind of seems like they're non-compliant and nobody's listening to what they're saying.
And it's sort of, for me, it pisses me off. And when I'm talking to the patient, like, for example, the patient, and this is why I wanted to do this podcast again today, is the patient that I had recently. She comes in, she's 31 years old, never had a baby before. We're sitting there talking about why is she seeing me? And she's seeing me because a friend of hers told her, if you want to lose weight and you're not getting anywhere, go see him. They can do some blood work on you. They can possibly give you what you see on TV, the injectables, the semaglutides or trizipidides. So I walk in the room and she's not even coming to see me for PCOS. She's coming for weight loss. And I walk in and she's got facial hair. She's got what we call acanthosis nigrans. It's where you look at the skin around your neck and it's not dirty, it's dark. That's the hyperpigmentation from the androgens. So I'm talking to her and I'm like, so can we talk about like your healthcare? And she goes, no, I'm here to get the shot. I want the shot. I said, well, what do you do for birth control? She goes, well, I used to have really heavy cycles and they were irregular. So my provider started me on the Depo shot. I go, so you're on Depo-Provera that works for 3 months. It's all progesterone. She goes, yeah. I go, how long have you been doing it for? She goes, 2 years. I'm like, great. How much weight have you gained in the past 2 years? She goes, 60 pounds. Yeah. I'm like, oh my God. And what we tend to do in this country, and at least physicians are getting better, but it's so sad, is that we treat symptoms, we don't treat the disease. And that's what pisses me off, is you have a patient that comes into your office complaining of irregular heavy cycles. So you give her a progesterone to shut her periods down, but you don't address the PCOS. And is it because she was African American and her mom's a big woman, or she was Hispanic and her mom's a big woman? That's what pisses me off. The other big thing is if you ignore these patients, and in my residency program, we saw this, and it leads to what's called metabolic syndrome. And the scary part is you ignore treating these women's diseases and you throw a Band-Aid on it for the temporary time. So you go from having increase in weight, irregular cycles, polycystic, depression, acne, hidradenitis. Then they hit the age of 35, they become a diabetic. Yep. Then they hit the age of 40, then they have high blood pressure. Then they hit the age of 50, they have a stroke. And then when they pass away, they go, oh, they just didn't take care of themselves, which they weren't educated to take care of themselves from their provider. And the other big thing, and I know that some drug manufacturers hate when I say this, but why do you think that these injectables came into fashion? The whole semaglutide, trizipidides. They're treating those 6 million women, not just women, but men, but those 6 million women that didn't get treated with diet, exercise, low carbs, birth control that worked on PCOS as well as metformin. And now they've become a diabetic.
Yeah. And that's, I think, like you said, when the lucky patients, the fortunate patients that come to see you before they have gotten to the point where they're a diabetic and it's established that they have PCOS and you're starting them on metformin, I can't tell you how many times a patient will call me back and be like, yeah, I went home and I talked to my mom and I was so happy about my appointment and, told my mom that I was started on metformin and they told me that the metformin is for diabetes and I don't have diabetes. And that's another kind of hurdle to cross with the patients is, yes, metformin obviously is a medication for diabetes, but in this circumstance, we're giving you metformin to treat the PCOS to make sure, you're not going into the diabetic stage, which then takes you into hypertension, which takes you to stroke.
And what we're trying to do when we're treating patients with PCOS is we're trying to bring down their insulin resistance. And one of the basic ways that I describe PCOS to my patients is I say, let's say you and your husband go out to dinner to a steakhouse. Your husband orders a steak, baked potato, cheese fries, bloomin' onion, the bread, orders all this stuff. Whatever he eats gets burned as energy. And what he doesn't use for energy gets stored as fat. You order a salad and a baked potato. What you eat gets stored as fat, and you have to break down that fat for energy. So it's like a reverse metabolism. So what does metformin do? With PCOS patients, it's not going to drop your blood sugar. It's not intended to work as a diabetic medicine. It's working to bring down your insulin resistance. Like when I was trained in residency, we used to always tell patients PCOS is for life. And it's how you manage it and control it prevents you from becoming a diabetic, having a stroke, having the weight issues. What I've found over the past 20 plus years dealing with this is if I have a patient who's got a high BMI, who's just not healthy with her diet and her insulin resistance, if I bring her BMI down and change her diet, change her perspective on life and how she's going to approach it with exercise, diet, eventually I take my patients off of metformin. They don't need it because now they've adopted a lifestyle of not a high carb diet. Because we all can believe it. Carbs are comfort food. I mean, it makes us feel good.
And I think a lot of the patients that you see that you're diagnosing with PCOS really are, you've got a handful of patients that are coming in because they're having irregular cycles and, they're not really sure what to do about it. They're not trying to get pregnant or have babies. And then you have the handful that have been trying to get pregnant for a really long time and undiagnosed PCOS. So then, that's another group. But then you also have a handful of patients that have had bariatric surgery and then they just kind of, after bariatric surgery, they're on this weight loss medication and they've just hit that plateau where they can't lose any more weight and they don't know what they're doing wrong. But then come to find out, those patients also have PCOS. So it's kind of like a double-edged sword. It's
nice that we partnered with a lot of the bariatric surgeons in our region because about 15 years ago, one of the bariatric surgeons and I were having dinner and we were talking about like hormone therapy and PCOS. And he's like, yeah, we'll do a gastric bypass or we'll do a sleeve or a lap band and that patient loses 100 pounds, but we can't knock off the other 100 that they're losing. And once we get them hormonally balanced or bring down their insulin resistance, they're back in perfect shape. But then it goes back to what I was just talking about. If we would have just addressed this when she was 20, we could have potentially avoided doing a lap band or a gastric bypass or being put on insulin. So I think that's the frustrating part. And I think in this day and time, women are becoming a lot more educated. They're taking their treatments. Like I'll see commercials on TV for these injectables. And do I write them? Absolutely. I probably write like 30 a week. But look at the commercial. The next time you're watching these commercials, half the women in the commercial have PCOS.
Yeah.
But no one's addressed it.
Yeah, you can tell, like you said, with the acanthosis around the neck, and just there's different, features that the women possess that you can tell. I mean, from, like Dr. Shabban said, I've been over here working with Dominion Women's Health for over 12 years, and I didn't realize how prevalent PCOS actually was, until a year or two into working here. And then, I mean, even now, I'll walk through the grocery store and I'll see somebody and I just want to walk up to them and be like, hey, do you know you have PCOS? Like, obviously I'm not going to do that, but it's part of me just wants to be like, if you're struggling, I know you have PCOS. I don't know if anybody's told you, but I can just look at you and tell you that you do. And if you need help, call us.
But it's one of my friends was like a conspiracy theorist and said, why would we treat PCOS if we can just treat the symptoms and make money as the pharmaceutical industry or the industry in general? And I'm like, because it's a human being.
Yeah.
It's a human life. So
would you feel that way if we were talking about your daughter or your wife or your mother? Is that?
Yeah. And then the patients will see us in our practice and they'll say, well, I had 3 rounds of IVF to get pregnant. And I'm like, if we would have just addressed this, and that's what's frustrating. So I think the big part of doing the podcast today is not just to educate, but I want people to have the tools that they can use to go get tested. We're not saying, storm the OBGYN's office or your primary care, but just look at some of the symptoms that you're having. Some patients with PCOS might have normal cycles, but they have the other issues going on. And instead of getting put on an antidepressant, which also has side effects of weight gain, let's figure out what's causing your depression or your anxiety or causing the hair growth on your body. So what I tell a lot of my friends, family, patients, because my patients are my family, is some of the diagnostic tests that you can get done at your physician's office is request an ultrasound to look at your ovaries to see if there's a bunch of little cysts. They call it string of pearls. Request to have blood work done. Let's check your androgens, the hormones in your body. So we'll check your FSH, your LH. Those are some of your ovarian functions. The other big thing is to check your thyroid. Sometimes your thyroid can mimic some of these symptoms, especially with PCOS patients. Like the hair thinning could be your thyroid, or it could be the androgens in your body. And then sit down with a provider. I don't care if it's a psychiatrist. If they know everything about PCOS, I would let them treat you. But sit down with someone that's knowledgeable with PCOS and talk about treatment options. Like one of the first treatments that I do with my 13 or 14-year-old patients is I put them into a diet and exercise program. We talk about a protein-sparing diet, try to avoid taking as much carbs, and doing like meal preps. So we have a program set up with one of the local gyms that they also do nutrition counseling. And then look at, if you get to the point of you're having to have medical treatment, do we want to go to the oral medication that brings down your insulin resistance? Or have we passed the fertility part where I need to put the patient on an injectable, on a semaglutide or a trizipatide, because we've bypassed that. And that's the other thing about like health insurance. That's a whole different podcast. I could have a patient that weighs 350 pounds, but if her pre-diabetes blood work, her hemoglobin A1C isn't above a certain level, the insurance won't pay for the injectable.
Yeah,
But they'll pay for her to go to the ER and get treated for chest pain, shortness. I mean,
it's crazy. I think another thing to note for the PCOS patients, if that haven't been diagnosed, all of the symptoms that Dr. Shabban listed, you could have, let's say there's 8 symptoms, you could have 2 or 3 out of those 8 and still have still have PCOS. You don't have to, here are your symptoms and check every box. Yes. Oh, okay, I have PCOS. That's not necessarily
And that's
true.
a good point that you say that, because early on in our practice, I would get a young woman who had infertility and she weighed 130 pounds and she was 5'7". And I would do the blood work and I'd say, you have PCOS? And they go, nope. I went on the Google and Google says I have to weigh 200 pounds. I have to be obese. And I go, well, there's the thin version of PCOS and there's the big version. But also, just like Britney was just saying, you could have 2 or 3 of the signs and symptoms of PCOS. You don't have to have everything. So, and sometimes if you only have 2 or 3 of the symptoms, they're even easier to treat than jumping straight into the metformin.
And that was me. I mean, I think maybe after a year after working with you and listening to you talk to the patients about, oh, well, if you have, irregular menses, hidradenitis, weight fluctuations. And I remember one day I was like, I think I have PCOS. And you were like, oh, I don't know. And I was like, I'm pretty sure I have PCOS. And you were like, all right, let's do some blood work. Because at the time I was like 22. I mean, I probably weighed like 130 pounds. But I had irregular cycles, and I remember that I used to get terrible, well, at the time, like when I would shave my underarms, I thought it was razor burn. And I was like, gosh, this is crazy. And then come to find out it's hidradenitis. And again, I wasn't checking every box for PCOS. Like, yeah, I have all 8 of these symptoms and I weigh 200 pounds. I think I maybe had 2 or 3 out of, the symptoms that were listed. And I did the blood work and I had the ultrasound, and Dr. Shabban was like, oh my gosh, you do have it.
So sometimes we're fooled. But I think the biggest thing about this podcast is just to make women aware that it's not like my grandmother used to say, she's big boned or that's your genetics. Yes, PCOS, you weren't born and just because your diet changed over the years or you ate Fruit Loops every day, you got PCOS. Yes, there is definitely a genetic component. But the biggest thing about this podcast is just, I want to make it every day more aware that 6 to 7 million women have PCOS. But the scarier part than the PCOS is that up to 70% of them go undiagnosed until they hit diabetes, high blood pressure, coronary artery disease, cardiac disease, and then they get into what they call metabolic syndrome. So I want to keep pushing this. And I think that instead of just doing one podcast a year in regards to this, our future podcast is, I want to see if I can get some of our patients from the past that have managed their PCOS, have had their kids, but look amazing and they're doing really well, to show you, hey, listen, this can be done. And as long as you work hand in hand with your provider, we can get good treatment.
I think just being able to, anybody that isn't sure, feels like something is off with their body, whether it's irregular menses or weight fluctuations or hidradenitis, mood swings, anything like that, and they're not sure, they've been to their OBGYN or their PCP or whoever, and nothing has been done, or is like, oh, well, just diet and exercise and I'll see you again, or you're depressed, here's some Zoloft, and you almost feel like, okay, well, I've been to these doctors and nothing's been done. I'm done trying to do this. Bringing awareness to there is a solution. And obviously we want to help you find that solution and help you in your health journey moving forward, whether you're in your early 20s and you just aren't sure why you're having an irregular cycle, or you're in your 30s and you've been trying to get pregnant for 6, 8, 12 months. It took my husband and I a year and a half because I didn't know I had PCOS for a long time. And then sat down with Dr. Shabban, and it was like, okay, you have PCOS, so this is what we have to do in order to be able to get you pregnant. I have a beautiful 5-year-old now. Or you're not trying to get pregnant, you've passed, you have all the kids that you want in the world, or you didn't want any children, and now you're in your late 40s, but something just feels off.
And you want to be healthy.
Yeah, you want to feel good.
I mean, it's not just about our fertility, it's about our health, being around for your kids and your grandkids. So I think that's the big thing is you can go on Dr. Google, you can go on WebMD, just get some information about PCOS. And my biggest goal is to just have women take charge of their health care and go to their providers to get worked up or get the proper treatment.
Yeah, if it's something you're questioning, just, go talk to your doctor and ask, hey, can you check and see if this is what I have?
Well, thank you for tuning in to our podcast on PCOS. Look forward to seeing you soon. Our next one will probably be on bioidentical hormones and how, since the first podcast I did to now, how things have changed over time. Tune in, take care, and have a great week.
Thank you.